Hello, everyone. Good morning, good afternoon, good evening, depending where are you located. My name is Antonio Harden, and I'm the director of the Child Psychiatry Clinic here at Stanford University. We continue with our webinars, focusing on different psychiatric disorders, including autism spectrum disorder, that are focused on supporting and educating individuals who are in Ukraine. We've had several presentations so far, starting with PTSD in children, second with psychopharmacology for individuals with autism, and last week we did one on assessment. Today, I am honored to introduce Dr. Urs Hassasari, who is a child and adolescent psychiatry fellow at Stanford University, who will be talking on anxiety in autism spectrum disorder. Before we ask him to start, I want to make sure that everyone is aware that there are translations in Russian and Ukrainian. And I would like to introduce Daria Orlova, who will be saying a few words about this presentation and about the interpretation.
Доброго ранку, добрий вечір. Я хочу нагадати, що ви можете задавати ваші питання у розділі питання та відповіді, а також обрати мову. Це така маленька планетка у вас у правому нижньому куточку. Українська для української, російська для російської мови. Дуже просимо друкувати ваші питання англійською мовою по можливості. Можете користуватися перекладачем у Гуглі або будь-яким іншим. Будемо раді взагалі, що ви прийшли. Я повторю, что вы можете выбрать язык, русский, украинский, либо вам удобнее. Также просим вас печатать вопросы ваши в Q&A на английском языке. Большое спасибо. Thank you.
Very good. Thank you, Daria. Just for information, the webinars will be available on the Stanford Autism Center website. You can go there and click on the specific lecture and review them. And for the next 3 weeks, we have speakers lined up. For May 11th, we have a presentation on pivotal response treatment. On the 18th, we have another presentation on problem behaviors in individuals with autism. And June 1st, we have a presentation that will focus on PTSD in children with autism. This information will become available on our website as we confirm these dates with the speaker. Thank you, everyone. And thank you for attending. And without further ado, Dr. Hassasari.
Thank you, Dr. Harden, for that introduction. And thank you, everybody, for having me here today. So my name is Dr. Urs Hassasari. Like Dr. Harden said, I'm a child and adolescent psychiatry fellow at Stanford University. And today we'll be talking about anxiety and autism spectrum disorder. I have no financial disclosures. So today we'll be discussing how common anxiety is in our children with autism and how it may present differently than typically developing youth. The first step to helping children reduce anxiety is to first understand what anxiety actually is and how it presents in our kids with autism. I will then be sharing some strategies on how parents and caregivers can help their children with autism manage their anxiety. Finally, we'll be discussing a few general approaches to treating anxiety in children with autism. So I'd first like to review the clinical features of autism and the conditions associated with the diagnosis. There are 2 core clinical features of autism required for the diagnosis. The first is a deficit in social communication skills. The second are what we call repetitive behaviors and restricted interests. For some children, they may have an intellectual disability, language difficulties, and medical conditions such as seizures. Some kids with autism will have irritability, which can lead to aggression, tantrums, and deliberate self-injurious behaviors. Finally, there can be a whole host of associated psychiatric conditions such as anxiety, insomnia, depression, hyperactivity, inattentiveness. There's a saying in the community that when you met one person with autism, you've met one person with autism. And this just speaks to how personalized each presentation of autism and all the associated conditions can be. The same thing can be said for anxiety, which I'll be talking about during this presentation today. When we think about anxiety, we have to first discuss what fear is. So fear is the emotional response to a real or perceived imminent threat that leads people to respond with either fight, flight, or freeze. In kids with autism, these can appear as tantrums or meltdowns, non-compliance with instructions, or shutting down. In situations where you aren't facing death or danger immediately in your environment, but still feel these symptoms, this is where anxiety comes into play. Anxiety is defined as the apprehensive anticipation of a future threat. It requires thinking about the future and being worried about something dangerous that will occur that's not currently happening right now. Anxiety is an emotion characterized by worried thoughts that might be recurrent or perceived as intrusive. Their minds might be going blank, or they might have difficulty concentrating, or they might have a feeling of impending doom. They may also experience feelings in their body related to tension in their muscles and physical changes like increased in blood pressure, sweating, tremors, dizziness, or a rapid heartbeat. They may avoid certain situations out of worry. They may frequently ask for reassurance. They might be pacing or restless, or they might have oppositional behaviors. When we think about anxiety, it can be very helpful in many situations because it allows us to think about things in the future that might need to be taken care of now, or that you might need to prepare for now for an event in the future. Examples of this would be if there was a big deadline or a test coming up for your kid. Anxiety can provide that motivation and energy to really prepare for this so that they'll do a good job on the test. In our children with autism, this can present with behaviors of avoidance, elopement, distress, and tantrums. However, when anxiety becomes excessive or persistent to the point of being unable to relax, or if it's out of proportion to what the situation actually is, it can cause significant impairment. And this is when it becomes a disorder. The impairment can be seen in school settings, at home, with their friends and social relationships, or when they get a little older, it can lead to problems with employment. There are three different models of how we think about anxiety and autism. They can be seen as comorbid, where the anxiety and autism are seen as distinct but traveling together. There's the complication model where autism increases the risk of anxiety. For example, if there's problems with social communication already, they might have more social anxiety because they don't know what to expect in social situations. Finally, there's a convergent model where anxiety is considered to be part of the autism, since the insistence on, for example, the insistence on routines and social avoidance might be the same thing we're dealing with as a core feature of anxiety too. We also need to think about the risk factors that might predispose to someone with autism to developing anxiety disorder. We think about what factors are specific to autism, the psychological risk factors, and the social risk factors. Factors related to autism included rigidity and inflexibility in changing between different situations or environments. They might have abnormal sensory processing, which leads to a lot of body symptoms associated with anxiety. They might have difficulties understanding or communicating what the social world expects of them or what they want from the social world, and that might trigger anxiety as well. Those who have a higher IQ in autism have been shown to be more prone to developing an anxiety disorder. There might be an intolerance to uncertainty, or a pattern of thinking where they may focus on a tree in a forest instead of the general picture. Socially, those with autism are at higher risk for family conflict, social conflicts, adversity, trauma. There might be loneliness given that it's hard for them to connect with other people. They may avoid school as a result, for example. There's a concept in autism called camouflaging, which refers to behavioral adaptations that individuals with autism, especially females, use to mask the symptoms during social situations. They're able to compensate for their deficits, and that individual is observed to have behaviors that are considerably better than their actual ability. This may hide their symptoms, and they may evade diagnosis well into adulthood, causing problems for them because they're not understanding why they're struggling so much, or other people aren't understanding why they struggle so much. How do we know what's effective in treating anxious youth with autism? First, we have to start with the big kind of things that we can observe, which would be the behavior. We then work backwards to categorize the clusters of symptoms into an anxiety disorder diagnosis. We can then agree on the diagnosis. Then we can develop specific interventions that could be used to target that one anxiety disorder. Finally, we collect the data on whether that specific intervention improved anxiety symptoms in that disorder to determine the effectiveness of that specific intervention. Over the past 20 years, the number of research publications on anxiety and autism has exponentially grown, and so has our understanding of what works and what doesn't work. When we look at the research literature, we see that there's a higher prevalence of anxiety in children with autism compared to the general population. Those with an anxiety disorder, those with an autism spectrum disorder diagnosis are about 40% likely to have an anxiety disorder diagnosis. Compared to those without autism, the prevalence is about 5 to 32%. There was a birth cohort study recently that looked at 31,000 individuals with autism and with anxiety disorders, and they compared it to age and sex matched controls and determined that those with autism were 3.5 times more likely to have a lifetime history of an anxiety disorder. When we assess for youth with autism for an anxiety disorder, we ask about the DSM-5-TR, which is the latest version symptoms, and we think about the unique presentations that are present in those with autism. We ask, are the symptoms new, right? Or have they been long-standing since they were an infant? Or are they causing impairment, right? And is that impairment also new? It's important for providers to be aware of what the core symptoms of autism actually are so that they can separate it from the anxiety disorders. We think about the stressors in their environment and what kind of social supports they have, because those might be predisposing or protecting the kid from developing an anxiety disorder. And we think about health promoting activities in the family or in the individual and the coping skills that they currently have too. The way that we diagnose anxiety disorders in our kids with and without autism is through the Diagnostic and Statistical Manual. We're currently on the text revision of version 5, which came out a few months ago. However, we also know that there are distinct presentations of anxiety disorders in children with autism that may not be typical, and I'll be going over some of these in a second. So the way that we've categorized anxiety disorders clinically is by what the person is anxious about. These are the 3 most common anxiety disorders in children with autism. In those with generalized anxiety, there is an excessive, persistent, and unreasonable anxiety about everyday things. They're anxious about many areas in their life, such as school, their friends, their family, their home life, chores. They have to be persistently anxious for about 6 months to get this diagnosis. And the anxiety has to be so difficult to control that it's associated with cognitive symptoms, such as difficulty concentrating, and physical symptoms, such as muscle tension or sleep problems. A person with social anxiety disorder is anxious about or avoidant of social interactions and situations that involve the possibility of being scrutinized. Those with specific phobia are anxious or avoidant of circumscribed objects or situations, such as heights, enclosed spaces, needles. In panic disorder, a person experiences recurrent, unexpected panic attacks and is persistently concerned about having more panic attacks or changes their behavior in maladaptive ways because of those panic attacks. Agoraphobia occurs when a person's anxious about the possibility of not being able to escape certain situations, or that they won't be able to get help for a panic attack if they're in those situations. So they avoid them or change their behavior in response to that. A kid with separation anxiety disorder is fearful or anxious about separating from attachment figures to a degree that's developmentally inappropriate. Finally, these disorders that were previously part of the anxiety disorders chapter in the DSM were separated out because they are seen as part of their own cluster of symptoms. In post-traumatic stress disorder, or PTSD, an individual experiences, witnesses, or hears about a life-threatening event that leads to symptoms of re-experiencing that trauma, such as nightmares, avoiding any thoughts or memories or reminders of that trauma, having negative thoughts or emotions, such as I'm a bad person, or it's my fault, or I blame myself for that trauma, and hyperarousal related to the memories associated with that trauma, which include high heart rate or being easily startled or scared, that's related to that trauma. OCD is characterized by the presence of obsessions and or compulsions. Obsessions are recurrent, persistent thoughts, urges, or images that are experienced as intrusive or unwanted, whereas compulsions are repetitive behaviors or mental acts that a person feels driven to perform in response to an obsession. These have to be time-consuming and last for many hours in the day to meet this diagnosis, because obsessions and compulsions are pretty common in kids. We know that those with autism have some atypical presentation of these anxiety disorders that neurotypical youth may not have. In social anxiety disorder, there might be social fears without the anxiety about the negative evaluation from other people. With phobias, they might have peculiar or unusual circumscribed fears. When we look at the categories of unusual fears, the most common unusual fear in those with autism are of mechanical things, such as blenders, can openers, toilets. The next most common unusual fears are of heights and weather and non-mechanical things, such as balloons, eyes on a toy, strings, stuffed animals, or a vent on a house, right? So these are kind of unusual phobias. In generalized anxiety disorder, anxiety might be more related to unexpected schedule changes or transitions, right? Or fears about special interests. With OCD, kids with autism might have a fear of contamination because they've encountered a situation where something was gross, disturbing, or having too much of a sensory overload in that environment, in that situation, or with another person, that they have OCD symptoms around that environment or around that person. So there are a couple of questions about how to tease apart overlapping symptoms. You know, it can be really tough to tease apart what's due to anxiety and anxiety disorder and what's more associated with autism. But here come some general ways that we can know, right? This is important because remember what I said before about those specific interventions. Those interventions that are geared towards those specific anxiety disorder might not be effective or appropriate if what the actual issue is one due to autism. Right? For social avoidance, it can be due to social anxiety, depression, phobia, or it can be due to just low social motivation or sensory issues or bullying because of the autism. Repeating the same worry over and over again could be seen in generalized anxiety disorder or OCD, or it could be due to perseveration due to autism, which is more of a repetitive behavior or mental act. Not liking loud noises could be due to a phobia, or it could be due to sensory overreactivity. Being upset when separated can be due to a separation anxiety disorder, or it can be due to what occurs in autism, which is a need for sameness, or they're actually dependent on the parent to obtain certain needs that they don't have the capacity to obtain themselves. And finally, a reduced pleasure in activities can be seen in depression and anxiety. Or in the case with autism, maybe they just have a limited repertoire of activities due to those restricted interests, and they're just fine doing that one or two things in their life. It's really important to know that with OCD, these over-focused interests doesn't mean that it's an obsession, and that repetitive behavior might not be a compulsion, right? And so these can be seen in autism and OCD, but they don't equal each other. When we look at the psychiatric diagnoses in the community of children with autism, we see that about 70% of them have had a psychiatric diagnosis other than autism. Anxiety disorder was about 40% in those in a sample of about 200 kids in the UK in 2008. A newer study in 2018 that was done in San Diego, California, with a publicly funded mental health clinic found that the prevalence of comorbid psychiatric conditions was even higher in this low income setting. 56% of individuals had an anxiety disorder in this setting, and 92% had any psychiatric disorder. When we think about also other kind of factors that might impact anxiety in youth, we think about the impact of war, which is relevant in Ukraine right now. There haven't been any studies looking at specifically kids with autism, but there was this study that came out this just last month looking at the impact of war on children in general, right? And the impact of war includes immediate stress response directly related to that precipitating factor, that event. There is an increased risk for specific mental disorders such as PTSD. There might be a lot of distress and focus on being separated from parents. And there might be fear for personal and family safety that might not exist if there wasn't that background of war in the environment. Potential interventions that they've proposed include providing basic physical and emotional resources to help children regain that external safety and inner security. They encourage screening and assessment of a children's mental health burden. The way that we can deliver care to more people is using short-term interventions and group-based interventions so you can help the most number of people in the shortest amount of time. There's also a need to support parents, because when you support parents, they're able to take care of their kids better. And then finally, providing post-migration infrastructures and social environments that foster mental health in wherever they're going to, right? The model that they used was based on Maslow's hierarchy of needs, with physiological and safety being the most critical things at the bottom of the pyramid, and the most time that is gained to, or the most benefit that can be had when you help with these issues. They argue that the interventions should be kind of parallel or mirror that hierarchy of needs, where basic needs and security are kind of the number one thing where most of the effort should be going to, and then community family supports, non-specialized supports, and finally specialized services are at the kind of the top of the pyramid, which is harder to obtain. So when we think about treating anxiety and autism, there are about 4 strategies to consider. These include therapy, family interventions, school interventions, and medications. The most effective type of individual therapy for anxiety in typically developing youth, as well as those with autism, is called cognitive behavioral therapy. CBT is an evidence-based treatment that can help people with anxiety, depression, panic attacks, and many other problems, and it's adapted for trauma as well. One of the key components in CBT is the cognitive triangle. So just briefly, our thoughts will have an effect on our feelings, and then when we feel a certain way, we may think certain things, and so there's this relationship between the two. There's a saying in therapy that can help with this process. You have to name it in order to tame it. Both thoughts and feelings will also change what we do and vice versa. So CBT emphasizes that relationship between our thoughts, our feelings, and our actions, and how each one changes or influences the other. Without intervention, this process can feel out of control and turn into an anxious spiral. During CBT, we know that it's difficult to voluntarily change how we feel. Therefore, the main thing that we want to change how we feel is changing our thoughts and changing our actions in order for it to affect how we feel, right? This type of therapy can be delivered in an individual or group setting. And a typical course of treatment is about 12 to 16 weeks, about 60 minutes each week. Between sessions, there's typically homework and practice and repetition in order to reinforce the concept learned in therapy. Special CBT adaptations are needed to facilitate understanding of cognitive and emotional concepts in those with autism. So these include the use of visual support, such as this fear or emotion thermometer, the use of written materials and lists, concrete language and examples rather than using nuanced details that could be confusing for somebody with autism. We tend to focus more on behaviors and exposures rather than thoughts and cognitions, especially in our lower functioning kids. We provide opportunities for repetition and practice while accounting for slower processing and attentional capacity. We break up these changes into smaller chunks so that they have more opportunities for success. We incorporate special interests into the therapy, and we encourage more active parent engagement in therapy in kids with autism. When we look at the effectiveness of CBT for anxiety in those with autism, we often turn to meta-analyses, which combine the results of multiple scientific studies. Most show that CBT is moderately effective for anxiety. This one by Perryhan showed that CBT was more effective when parents were involved, and that you need at least a standard length of treatment of 12 weeks for effectiveness rather than 4 to 8 weeks. The second meta-analysis by Ung showed that parental involvement didn't moderate effectiveness, right? It didn't matter if parents were part of it, or if the CBT was individual, or if the CBT was delivered in a group setting. It didn't change how effective it was. And then they also found that the effect doesn't depend on who reports or who is doing the anxiety scale. This latest study in 2021 showed that when you separate out who reports improvement rather than pooling the data across informants, there are different effect sizes. Clinicians reported the largest effect size on the kids' autism, whereas children reported the smallest effect size on their anxiety. CBT has also been implemented in school systems. So this paper looked at 6 studies of therapy interventions in school settings. All of them use CBT protocol, either adapted from neurotypical youth or ones that are specifically made for children with autism. They ran from about 6 to 32 weeks, about 1.5 hours each session, and all of them were in groups of 3. They found that school-based interventions were moderately effective at decreasing anxiety in youth with autism, and only slightly less effective than in individual therapy settings in the clinic. These school-based interventions use CBT approaches, which includes teaching students how to identify emotions to understand them better, teaching them anxiety management techniques such as deep breathing, relaxation, problem solving, cognitive self-control strategies, and using graded exposure strategies such as spacing fears from the easiest to hardest fear with the therapists and groups help. Interventions that were more specific to autism included using lots of visual aids and visual cues, and using lots of social stories, because we know that kids with autism really respond to these stories and these examples. With regards to family interventions for anxiety, the number one thing that parents can come to me for is because of problematic behavior that causes issues for them at home or at school. So the first step is to therefore define the behavior that is so disruptive to their lives. An example of this would be when a child's asked to get ready to go to school in the morning. They may throw a fit, they might ignore the request, they might run away and hide in the closet. This behavior is problematic because it prevents us from going out the door and getting to work on time. But what's the real problem for the child though? Because they don't care about us going to work on time. Is he having anxiety in school because he's trying to avoid delay having to experience that, right? Or is it more that he's struggling with transitions because of the rigidity and he's uncomfortable with change? Could it be due to sensory issues, right? Maybe he's really sensitive to clothing and it's really uncomfortable to change from those comfortable pajamas to school clothes. Or did he just get bad sleep last night and he's really irritable because of that? So the first goal as a parent is to help figure that out. But how do we do that? Right? How do we determine what the underlying cause is? We need data. We need signs, symptoms, and monitoring for these behaviors, right? We get that information from clinical evaluation by therapists, a psychiatrist, a clinician. We get that information from the school under behavior or academics, right? If there's a counselor or a behavioral aide in the classroom, they can provide that information in addition to what the teacher can provide. If the child is verbal enough, they can tell you what they're feeling or why they're behaving the way that they do. And as a parent, you can ask your partner or any other caregiver that might be involved for their observation as well. It's important when collecting the data to think about the arc of anxiety exacerbation. So when does it start? What provokes it? What happened right before it, right? Where does it happen? Is it at school, in a particular classroom, or with a particular person or other kid? Is it inside the home or outside the home, right? What's the worst episode they've had? How bad does a typical episode get? Do they throw a tantrum or break things or become violent towards others? How long does it last? And finally, what happens afterwards? Do they get punished? Do they get attention? Do they get comforted or reassurance? Do they get their, what they want? When we think about the function of behavior, this last point is really important because when we look at the things that happen beforehand, those are called antecedents, and we look at the things that happen afterwards, which are called consequences. The function of a behavior can be determined by what happens that follows that behavior. Okay. Some of the most frequent functions of a behavior is to get attention. It can be to escape or avoid something that feels overwhelming or too difficult or too anxiety provoking. Right? They might get a tangible item that they enjoy in response to a behavior, or there might be some automatic reinforcement. This last point is a reinforcer or reward that's not mediated by other people or social interactions, right? It's the meaning that it's non-social in nature. For autism, automatic reinforcements include self-stimulation, sensory functions, stereotypy, which are these repetitive kind of behaviors that they do over and over in the exact same way. So parents can learn to determine how to respond to a behavior based on what the function of their child's behavior actually is. And when we think of consequences, we think of things that can either increase behavior, which are referred to as reinforcements, or those that decrease behavior, which are called punishments. In order to reinforce or punish, we can either add a stimulus or remove one. If we add it, this is referred to as positive, and if we remove it, this is called negative. Positive reinforcements is that when you add something nice to increase a behavior, such as giving praise or giving them their iPad. Negative punishments are when you remove something bad, such as when you nag or bother a child to do their homework or chores. And then when they actually do it, you stop nagging them. That goes away. For positive punishments, this would be adding something bad to decrease the behavior, right? Such as being reprimanded, scolded. Whereas negative punishments are a little bit tougher to understand, but this would be taking away a privilege like an iPad or taking away something that they like. When a kid doesn't do something when a kid does something they aren't supposed to do, right? So if they have a bad behavior, you take away something that they like. There's a concept tied to negative punishment that when you take away something that a kid wants, this will likely increase the bad behavior until it gets so bad that we'd rather just give them that thing that they want to calm them down. However, if we hold consistent for long enough, something happens called an extinction burst, right? Where the kid learns that no matter how hard of a tantrum they throw, how much they try and how bad they get, they're not going to get that reward and will therefore learn that that doesn't work, right? So they decrease using that behavior or decrease that behavior to try to get that reward. When we teach parents to manage their children's disruptive behavior, it's more effective to focus on the desirable behaviors rather than the undesirable ones. The goal would be to increase the positive behaviors. In most homes and schools, lots of attention is given to negative behavior, but this might not be the best approach and might actually do the opposite of what you want. Right? Anytime when you give it an attention, which is a reinforcer to a kid, it increases that behavior, even if it's a problem behavior. Right? So the most effective strategy in shaping behavior is to give positive reinforcement. It's much easier to increase the behavior by rewarding them than to decrease the behavior by punishing them. So even though punishments can work, they're much less effective than reinforcements. However, what if we want to decrease a behavior that's problematic? If that's the case, then what we want to think about is how to use positive reinforcements in those situations. Right? We utilize something called the positive opposite. Basically, you want to take the problem behavior and come up with the desired behavior that's the opposite of the undesired one. This positive opposite has to be incompatible with the problem behavior. Instead of punishing that behavior you want to decrease, it's much more effective to reward the positive opposite behavior to increase an action that can't occur at the same time as the undesired one. So let me just give you an example because this can be a little bit difficult to understand. If I want to have my kids stop yelling in the house, I wouldn't give them attention each time they yelled in the house because that would reinforce that behavior. What I would do is I would ask them calmly to use their indoor voice. And each time they do, I would praise them effusively as a reward, or even give them something tangible like a candy or like the screen time. Giving gratitude and praise really works to increase behavior, not just in kids, but in adults too. You might feel torn, because as a parent, on the one hand, you might feel the need to reassure your kid and help him or her experience less anxiety. On the other hand, you might feel that by reassuring your child or accommodating to the anxiety, you're not doing enough to promote the child's self-sufficiency. So many parents feel the opposing poles of these two poles, which can result in an inconsistent fluctuation from a stance of being overprotective to one that's over-demanding. So children who suffer from an anxiety disorder tend to rely on their parents for avoiding that anxiety. For children with anxiety disorders, this pattern of behavior actually maintains the anxiety in this endless cycle. Right? Accommodation refers to any actions that you might be doing, even things you're deliberately not doing because of your child's anxiety disorder. This can be something like speaking in place of a child for if they have social anxiety, or sleeping next to a child who fears of being in bed alone, or answering questions or repeatedly reassuring them in response to their persistent worry. And so in order to break the cycle, we need to then remove or decrease the accommodation so that their kid faces their fears and this cycle can be kind of broken. There's a form of therapy called SPACE, or supportive parenting for anxious childhood emotions, that helps parents learn how to decrease their accommodations while increasing the support. Here we have an equation of support is a combination of accepting or validating a kid's emotions and how difficult it is, plus having a statement of a belief or confidence that the kid can overcome or deal with that difficult emotion themselves. When we have just one or the other, the kid may not experience being supported. For example, if we validate their difficult emotions without telling them and behaving in a way that we're confident that they can handle the emotion, it may come across as overprotecting. When parents do this, they tell me that their child can't handle the stress, or it's their job to protect them from all the negative emotions, or that anxiety can hurt or damage their kid. On the other hand, if you express confidence without validating how tough these emotions are, it may come across as over demanding, right? So parents tell me that they're, don't be a chicken to their kid, or they tell their kid, hey, the task isn't scary at all, you shouldn't be worried. Or they're acting like this for attention, even though they're fully capable of doing that, when in fact, they would just like their parents to accept how hard it is for them to overcome that emotion. So there's a whole menu of strategies that parents can use to determine the function of a kid's disruptive behavior. Anxiety is often the most pressing thing to address because it can really significantly interfere. It can lead to the fight, flight, or freeze response, and it's really hard to come back from that. You have to wait it out. Once you have an accurate guide on understanding your child, we can then start developing some strategies to try. Right? Sometimes it's guesswork and shooting in the dark. And I like to try things that are more in our control first. The first would be to modify the environment. Was this behavior an alarm reaction to an unexpected change in the schedule? We can then make sure we have a big family calendar, visual reminders of what's going on throughout the day. There are things that we can modify in their environment to manage their anxiety. We also need to manage our expectations on what they can accomplish and manage across all areas, whether that's social, academic, or behavioral. Maybe they can do a one-on-one play dates, but they can't do big birthday parties or unsupervised neighborhood play. So some families, we can work out strategies where the child goes out into the neighborhood for that unstructured play, but carries a walkie-talkie, to communicate with the parents. Or maybe they should take more frequent breaks when conflicts or when they're getting frustrated, right? Sometimes just keeping more breaks and limiting time to a shorter amount of time can help them have more success and make it easier, right? If things are tough and you've tried many different approaches, it could be helpful to have a therapist come up with additional strategies for the parent or to have the child meet with the therapist. And then when behaviors are so severe that when therapy or school-based interventions and family interventions have been unsuccessful, we then next turn to medications to help with our children's anxious behaviors. When the behaviors are so severe and when these strategies don't work, medications can really help with anxiety. There are actually no, FDA is something that the US has, the Federal Drug Administration, to approve if medications are safe and effective. There are no FDA approved medications for anxiety, specifically looking at youth with autism spectrum disorder. And much of what we do is extrapolated from use in typically developing youth. However, there are 2 medications that seem to be safe and effective that are FDA approved, and those are for autism-associated irritability, which is the FDA defines as aggressive behavior, deliberate self-injurious behavior, temper tantrums, and quickly changing moods. These 2 medications are aripiprazole and risperidone. About 42% of children with autism are on a psychotropic medication when we look across 47 different studies of 300,000 children. About 23% of them were on more than just one medication. The most commonly used psychotropic medications were antipsychotics, which isn't surprising because those seem to be the most effective and the most safe because they've been studied the most. Antidepressants can help with the depression or anxiety, and that's kind of the second most used in addition to psychostimulants for ADHD or disruptive behaviors. The use of specific anti-anxiety medications were reported among 7% of children. When we use a medication for youth with autism, it's imperative that we pick a specific target behavior for that intervention. The goal would be to decrease the intensity, frequency, and duration of these behaviors. And if it doesn't work after a couple of months and it's an adequate trial, then there's no point in continuing them, right? Because these medications aren't benign. And when we think about medication, we also talk about supplements too. If the supplement doesn't work after several months, then why would we use it, right? And so some target behaviors include anxiety, agitation, which is defined as being overstimulated by the environment, leading to increase in physical activity, aggression, which is more so hostile or violent behavior towards others, deliberate self-injurious behaviors such as hitting themselves or cutting themselves, hyperactivity, which is independent of environmental stimuli and more so driven internally, inattention and trouble focusing and trouble sleeping. The main medication that we use in children with autism for anxiety are the selective serotonin reuptake inhibitors, such as sertraline, fluoxetine, citalopram, and escitalopram. These medications have robust evidence of efficacy for anxiety in typically developing youth without autism. They haven't been systematically studied in kids with autism for efficacy in anxiety, but they're commonly used. And in my clinical experience, they've been effective and safe. However, we know that when we start this medication, they're more likely to have behavioral activation, which is being more agitated or having more anxiety maybe at the beginning. Sometimes we wait this out if it's not severe and it goes away. but sometimes it doesn't go away. And when it's so severe that it's causing problems, we can either reduce the dose or discontinue it, and then retrial later on to kind of establish that relationship between the medication and the agitation, right? When you look at specific anxiety symptoms, you can use specific medications for each anxiety symptom. For sleep disturbance, we sometimes and often use melatonin, 2 milligrams up to 10 milligrams at bedtime. And this has been robustly studied in children with autism. There's strong evidence for this to help with sleep issues. Clonidine and trazodone are medications that require prescription in the US, and it can help with sleep. More of the body symptoms of anxiety include increase in heart rate or blood pressure or sweating or muscle tension. Medications known as alpha agonists can help with these physiologic symptoms. And these include clonidine or guanfacine or beta blockers such as propranolol. For behavioral dysregulation, we also use alpha agonists. If they're severe and if there's harm to self or others, we'll use an antipsychotic such as aripiprazole or risperidone, which are FDA approved for this indication in youth with autism. And then for situation anxiety, such as if they need to get a blood draw or if they need to go to the dentist, we use a benzodiazepine such as lorazepam or a beta blocker such as propranolol for these situations. There are a couple of studies that looked at anxiety medications in autism. So here is a randomized control trial of using buspirone for restricted and repetitive behavior in young children with autism. They didn't use anxiety as a primary outcome measure, but they found that, and they didn't see that it decreased the repetitive and restricted behaviors. But overall on ADOS, but when they used low doses of 2.5 milligrams twice a day, it did show that there was some decrease in restrictive and repetitive behaviors. And when we looked at the secondary outcome measures, there was a significant reduction in anxiety when they used a 2.5 milligram dose, but not the 5 milligram dose. And overall, buspirone is well tolerated. So this study just came out last month. This is the first randomized double-blind placebo-controlled randomized trial for a medication for the primary treatment of anxiety associated with autism. So they use a medication called mirtazapine. Mirtazapine is an alpha-2 antagonist, meaning it blocks this receptor in the brain. And when you block this receptor, it causes norepinephrine release in the brain. And that down the line increases synaptic serotonin levels. Mirtazapine also blocks histamine, which is helpful for sleep, but also causes side effects of weight gain. 5-HT2 and 5-HT3 receptors. These are serotonin receptors that are located in the brain, and 5-HT3 receptors are located in the gut, so it is less likely to cause upset stomach. The improvement on the pediatric rating scale was clinically meaningful, but not significant when compared to placebo. Right? The effectiveness of mirtazapine in anxiety was reported in naturalistic retrospective studies, and so that's why they wanted to do this randomized control trial. So, mirtazapine is typically well tolerated, although there can be weight gain or sleepiness, and it's an option to consider. For medications in kids, but especially in youth with autism, we start at a low dose and we titrate up slowly. We closely monitor for side effects. And then we know that kids with autism are more likely to have side effects, and medications tend not to be as effective as typically developing youth. So in summary, autism and anxiety disorders commonly occur in those with autism and may be challenging to differentiate between the core symptoms of autism as well as from other psychiatric conditions. Cognitive behavioral therapy, when delivered in school in a group setting or an individual therapist, can be effective at decreasing anxiety in youth with autism. Parents and caregivers can determine the function of a behavior, how to intervene by altering the consequences, and reinforcing the desirable behaviors and the positive opposite ones. And then medications can be helpful to reducing anxious behaviors when they're too severe or when behavioral strategies have failed. I would like to point kind of attention to this Lancet article that was just published this year that talks about the systemic kind of treatment and interventions for the clinical care and research in those with autism. And it kind of summarizes all of the different approaches that have been used so far and some of the future directions that can be looked at in those with autism. Thank you for having me come speak, and I'll go ahead and take questions.
Okay, thank you, Dr. Hassasari, for this comprehensive lecture. It's great that you were able to cover a broad range of topics that are related to anxiety, looking at the different types of anxieties, but also looking at different types of treatment. We have several questions. And for the audience, if you have any questions, feel free to send them right now to the Q&A, or you can put them in the chat, and we have Daria or Dana who will be able to translate them into English if they are in Russian or Ukrainian. And please, when you try to ask the questions, make it a little bit more general. I know some of you have specific questions regarding your kids or regarding a patient that you are working with. It's better if the question is a little bit general. Okay, so the first question is, what are your thoughts about nail biting in a young children with ASD and possible ADHD? Do you think it's attributed to anxiety or boredom or understimulation? That's the first part of the question. And the second, what is the treatment of this behavior?
Yeah, so this is a common thing that kids do is nail biting, right? And kids with autism, it can actually be, it can occur, and kids with anxiety, it can occur, right? So how do you separate between the two? So this is a great question about behaviors in general. When we think about these behaviors that they're doing, we tend to look at, again, when the behavior occurs, right? Like, so are they nail biting when they're asked to go out to school, or are they nail biting when they're doing their homework, or are they nail biting for something that might be associated with anxiety? You know, that's what we would want to kind of evaluate when this occurs, what provokes the nail biting, or are they just doing it in all situations, whether they're bored, whether they're happy, right? When you think about someone being happy and excited, you know, you don't think about them being anxious a lot of the time. And so if they're nail biting in those situations, then it might be more related to a sensory stimulation, or they like how it feels on their teeth, on their nails. And that might be more related to the autism. Regardless of what it is, I think the treatment can be similar, right? One is, you know, when they're nail biting, you know, you can use a mild punishment. You can either ignore it or, you know, use a punishment. What's more effective is that when they're not nail biting in situations where you would think that they are, giving them rewards or praise or a lot of reinforcements can actually be helpful, right? We do something called systematic desensitization to get them to do it less and less. If this is related to anxiety, we kind of work on those anxious behaviors and thoughts and what they're anxious about, and that might decrease that associated behavior. So, you know, a little bit is focused more anxiety. Some of it can be ASD, but we look at the function. We look at prompting, for example, what happens before behavior, and then we try to kind of intervene that way.
Very good. Let me add that when we see nail biting, usually the approach is to think about anxiety and trying to identify things that are related to anxiety that we can work with. So it's treating anxiety until proven otherwise. Sometimes, like you mentioned, it might be associated with understimulation or boredom when it becomes a little bit more of a habit, and there is some conditioning that takes place there. And part of the treatment is to try to undo or unlearn this level of conditioning. It's important as you're trying to assess that, trying to identify the stress that the individual is experiencing. You know, sometimes you see an increase in nail biting around tests for kids in school. For kids who are on the spectrum, who are minimally verbal, you see that when the kid is faced with a new environment, that they are going to a new center for either school or for treatment. So that it could be stress-induced with an anxiety underlying it. When it comes to treatment, usually it's behavioral until you run out of options. And behavioral, you have progressive desensitization. And sometimes for some kids, actually what we've done is ask them to wear gloves. So that will prevent them from biting their nails. Sometimes you put a nail polish that's a little bit, not a great taste, to kind of use a negative conditioning or a negative reinforcement from them, so they don't bite their nails. The last result is usually medications, and we've used medications at times, especially with kids who have their nail biting led to tissue damage or bleeding. So we've seen that a lot of bleeding and sometimes infection in the nails. So that's when you have to be a little bit more aggressive. Try first the behavioral intervention, and then after that, if it's not successful, you can try medication. And we've tried different kind of medications over the years, definitely anti-anxiety. We also used medication that are from the family of the antipsychotic when really there is a significant tissue damage. Okay. Thank you for this question. The next one is anxiety in toddlers. Can it be mistaken for rigidity, which most ABA therapists want to fix by exposing children to more change, which in turn causes more anxiety? And the biggest question is, how can you tell whether anxiety it's related to autism, it's anxiety itself, or it's related to rigidity, inflexibility? Any thoughts about that?
Yeah, when we think about anxiety, we think about exposing them, right? This is exactly what the ABA therapist is doing, is exposing them to these anxious situations, helping them use some strategies to calm themselves down. Typically with these anxious situations, there might be some more anxiety when exposed to the situations, or there might be anxiety when exposed to new situations, right? There's a lot of transitions that happen every single day. And so we tend to work kind of gradually from the least anxious to the most anxious in that fear hierarchy. So it could be, right? Anxiety could be related to rigidity and anxiety, but we look at the associated symptoms and we try to treat the anxiety first and see if that works. And if they're still having issues with those transitions, and then we see what remains, right? I don't know if you have any thoughts, Dr.
Yeah,
Hardy.
so let me add some thoughts. So the critical first step is try to understand or try to figure out what's the primum movens, what's the first thing that's happening. So if it's a free-floating anxiety, that's what you're gonna see first before you see other behaviors or the consequences of the anxiety. In this case of rigidity and inflexibility, the anxiety is secondary to something that's affecting rigidity and inflexibility. So, and that's not very easy to figure out, especially, and that's related to this next question, which is in a toddler. So if you have a 2-year-old, 3-year-old, 4-year-old, it's very hard to figure out what is the first thing then that's happening. So especially in kids who are not very expressive, especially in older individuals with autism who are not expressive and cannot express what's going on internally. So if somebody is fearful of something, let's say has a phobia or the fear of has a fear from a snake or from something, so the first thing that's going to happen is that the expression of that anxiety. While in the case of rigidity and inflexibility, there will be something in the environment, either a change in the route that you usually take with your child to the school, or the TV is not in the right place, or the couch is not in the right place. So that change in the environment is going to trigger anxiety. In this case, anxiety is secondary to the rigidity and inflexibility. Something that's also challenging with regard to anxiety. Anxiety is an internal state. So it's very hard to assess exactly the anxiety without the individual himself, herself, or themselves expressing what's going on. So that's why there are a lot of guessing going on, especially in toddlers, especially in individuals with autism who are minimally verbal. But because of what Hassasari mentioned with regard to the prevalence rate and the high prevalence rates of anxiety in children with autism and individuals with autism, we have to very quickly think about anxiety as one of the causes of any change in behavior of any behaviors, whether it's a toddler or an older individual. And I've said that a few times over the years, is one of the things that have changed in my practice over the last 20, 25 years, is how soon or how early I start treating anxiety. It doesn't have to be with medication, but with either cognitive behavioral therapy or environmental manipulation, or if needed, the medications. So with regard to toddlers, if you're suspecting anxiety, it's important to consider that and see how it can be treated. Very good. So Dr. Hassasari, I don't know if you have thoughts about what are the red flags in a toddler who has anxiety from a behavioral point of view or from a symptomatology point of view?
I think that the red flags are if they're trying to cope with that situation in a certain way, right? Like what's the function of that behavior? What are they trying to get with that problematic behavior, right? And when we observe the kids who have anxiety, we see that they try to do a lot of different things, right? They try to escape or avoid. That's the number one thing that happens with anxiety, is that they try to avoid it. They try to have their parents help out, right? For them to deal with it, right? And so those are kind of, for me, the red flags of this. And of course, if they're, verbal enough, they can tell you. If they're not verbal, then you really have to rely and kind of guess. But, but we have to kind of think about it, especially if there's something is precipitating that anxiety as opposed to it just coming out of nowhere, right? We have to really look at the situations where that behavior is happening.
And anxiety can emerge at any time. So even in toddlers, so any change in behaviors, any challenges that you're seeing with your toddler or their preschoolers, change in behaviors, change in sleep, change in eating habits, being on the lookout, inhibition, which means being a little bit more not very mobile, watching a little bit the environment. So all of these are indicators of anxiety. Unfortunately, we don't have like a test or like a blood pressure or pulse that will allow us to measure anxiety in toddlers. We have to rely on our clinical observation, and we usually rely on actually the parents. And part of our work is to try to teach the parents to become good observant so they can report to us what is going on with the child so we can try to treat that. Is it easy? No. And that's why we're discussing it right now. That's why you have to rely on expertise or on experts in the field of anxiety and the field of anxiety in toddler to help you out with with figuring it out, and more importantly, in the treatment. Okay, let's move to the next one. These are questions that are very informative, and hopefully everyone is contributing. Okay, could you explain to medically treating anxiety when an individual who has ASD or ADHD and mixing anti-anxiety medication with a stimulant, which is treating ASD or anxiety on top of ADHD or ADHD on top of anxiety from a medication point of view?
Yeah, so this can be really hard to kind of tease apart from one another, right? Are they just more active and like moving around more because they're anxious, or is it like due to hyperactivity and impulsivity from ADHD? And so there's a couple of different approaches. You know, the main approach is to treat whatever is worse, right? If the ADHD is worse, they can't focus, they are really impulsive or hyperactive, then we use a stimulant first and we see what's left over, right? So we don't do this both together. We wouldn't start an anti-anxiety medication and a stimulant in most cases. In some cases we do, but in most cases we won't. And you know, we treat one first and see what's left over. So if you treat the ADHD and, you know, they're able to think more and be more focused, that might actually help the anxiety, right? That might make them able to have more cognitive self-control, more emotional regulation. So that happens in most cases. In some cases, the stimulant can actually make the anxiety worse, but we have to kind of see what happens after using it. We wouldn't use it just because of that fear. Or is the anxiety worse, right? Are they so worried? Can they not focus because they're so worried about like getting a bad grade on a test, or they might be worried about like performing, right? Whereas, you know, difficulty concentrating on a test from ADHD would be they're just more distracted by things that they like, you know, these novel stimuli in their environment. So you have to kind of look at what are associated. So if it's due to the anxiety, then we would use an anti-anxiety medication like the selective serotonin reuptake inhibitors. And then we would see like, does that actually help with their concentration and their symptoms of like being overactive, right? So we treat that first, and when we get to a good level, when we think, okay, they're no longer anxious, we can then treat maybe any ADHD that's left over with the stimulant medication. And using both of these together is something that we commonly do. We just want to make sure that there's no drug-drug interactions. And so using kind of an online like drug-drug interaction checker can be helpful for that. But oftentimes we combine an SSRI with the psychostimulant medication, and patients do well on the both of them.
Very good. I'd like to add a few things. Thank you, Dr. Hassasari. So one of the most humbling things in the field of autism is to treat anxiety or trying to figure out whether the behavior that's being exhibited in a 5-year-old, 6-year-old is whether it's anxiety related or ADHD related. And I can tell you that on a regular basis, we miss one or the others, because if you have a 6-year-old, 7-year-old who is minimally verbal, how would you manage to figure it out? So sometimes we have to make our bets, and based on the input of the parents, like Dr. Hassasari mentioned, we can make a decision to go and treat anxiety, because that's the impression that they have. It's mostly anxiety versus ADHD. And very often we try, or sometimes we try with treating anxiety and we realize that we're not making any progress. We go back and we treat with a stimulant. So unfortunately, in these situations, trial and errors is the best way moving forward. Are we on target 100%? Probably not. Do we miss? Yes. Something important with treating with stimulants in kids with autism, especially in light of the high rates of anxiety, is that stimulants can make the anxiety worse. So that's why sometimes we try not to use a stimulant, even though they are first line for the treatment of ADHD. We try to use other medication, non-stimulant, that are a little bit gentler on the anxiety. Something like, atomoxetine or clonidine or guanfacine, that are a little bit gentler on anxiety, not as effective for ADHD, but at least to minimize the impact of the medication on anxiety. Okay, Next question about anxiety when routine changes happens unexpectedly. How to help kids to recognize their emotions and to cope with them?
Yeah, this is tough because it's unexpected for a reason, right? It might make not just your son anxious, but also you anxious. And so, I think that we first have to kind of work with them on coping skills for if they get anxious when with routine changes overall, right? Whether it's expected or unexpected. And so I think that recognizing emotions and coping with them can be helpful in kids with or without anxiety, and I think that would be the first step, is to talk about and talk with them, right? Talk with them. Remember I said before, name it to tame it. You need to help them figure out, like, this emotion is helping me feel a certain way. And that's what they do in cognitive behavioral therapy, right? When there's a situation, how do they feel about the situation? And what kind of thoughts give them that anxiety? And so really, like, verbally talking with them. With kids with autism, we want to use concrete languages. Sometimes we actually use stories that are related to unexpected routine changes, that it's not like necessarily about them, but these stories can help them think about and process it in a way that doesn't feel directly related to them, so it feels a little safer, but they can use those lessons from that story in their own personal life. And so finding those stories can be really helpful. Now, when the routine changes unexpectedly, try as much as possible when you know that it's an unexpected change to give them a heads up, to give them a visual cue or reminder, right? And so you can give a 30-minute warning, a 15-minute warning when that's going to change. If it's happening right away and immediately, sometimes you're unfortunately left picking up the pieces afterwards and trying to help them reflect on and think about in the past, like what they felt and what they did with their body, what they were thinking, and those sorts of things, and kind of guiding them along the path of things that are more helpful or kind of better coping strategies.
Very good. Let me add one comment here, is that if you're working with a child that you notice that are very rigid, it's important to start thinking how you can loosen up that rigidity before an external event takes place and will force them to deal with this, with the changes in routine. As you all know, in a time of war, a lot of unexpected things will happen and you have to be flexible. So that's why identifying these patterns and try to work with them with your behavioral person is a good place to start before major things will happen. Sometimes it's possible, sometimes it's not possible, but that's something to keep in mind and to start working on them and introducing some minor changes. To give you an example, if a child is used to follow a specific route to go from home to school, and if you change a little bit, they will get upset. So trying to work on that, to loosen up a little bit that rigidity. Sometimes it takes a while. Just making a right turn instead of a left turn could take a lot of practice. So try to do that and anticipate, because as you all know, we cannot control the environment 100%, and trying to adjust to that will be, and plan for that will be helpful. Easier said than done, but trying to do that as soon as it's possible, as soon as you realize that rigidity is a major issue, is important. Okay, I'm gonna skip your question when I go to sweat.
Can I ask you to, we have some question about the war. So
Yeah,
can
I'm
you
going there.
give the answer?
Yeah.
Okay.
So that's what I wanted to skip some questions, and we'll go back to them if we have time. So a question about a 3-year-old child with autism in a bomb shelter began to play with ropes. After that, interest changed to, like, in various laces, ropes greatly intensified. He plays with them everywhere now. Should we try to switch it, or it's a way of coping with anxiety. I don't know if you have any thoughts, you can start and I will add.
Sure. I have kids with autism that aren't in bomb shelters that are also interested in ropes and knots. And they learn this typically in what we call, there's a Boy Scouts here in the US. I don't know if it's international as well. But they learn these things and they really like it. They're fascinated by like untangling knots and things like that. I think it depends on what they're doing with the rope, right? Are they like wrapping it around themselves and like tightening it to the point where they're hurting themselves, or are they just playing with it in their hands, right? Like as a fidget toy or as something that's fun. I think looking at like when they play with it and what happens when they play with it, right, can be really helpful. It's tough in a bomb shelter because it's hard to observe the kid. There's obviously reason to be anxious, right? And we typically in those anxiety-provoking situations, like in a bomb shelter or when there's an alarm in the community, that we ask people to use coping strategies, right? So one way that you can help, you can let them, play with the rope if it's helping them with the anxiety. Like what happens if you take it away, right? Like, are they going to be more anxious? And if they don't have other strategies, other coping skills to deal with anxiety in the bomb shelter, they might get more anxious and there might be more disruptive behaviors that emerge. And so sometimes if you're worried about the ropes, you can try to teach them other skills or other ways to cope with that anxiety, such as deep breathing, muscle relaxation, listening to music, other toys, so that they can have a variety of things that they can use other than ropes. Right?
Yeah. So is that interest in ropes is going beyond being in a shelter a way to deal with anxiety? Yes, that's a very simple. We all have different ways to deal with anxiety, and kids on the spectrum, especially a 3-year-old, is going to try to use coping mechanisms that are easier for them to use, such as using a lace or a rope and try to spin it or twirl it on a regular basis. Now, when it comes to these repetitive behaviors and whether we should try to switch them or get rid of them, the field is a little bit not clear about that. And probably there are some behavioral people who will work very actively on trying to treat stereotypic behaviors. And some people will say, no, you have to try to manage them. So you're probably hearing conflicting perspective on that. We can tell you a little bit the way how we think about it, and it might not agree with a lot of people, but this is a little bit our perspective for it. Some of these repetitive behaviors, they are used as a coping mechanism to a wide range of things. And as Dr. Hassasiri mentioned, repetitive behaviors are behavior that we see in typically developing individuals. So it's part of the brain maturity is to express these kind of behaviors, repetitive behaviors in the developing child, in our situation in children with autism. The only tricky thing within the individual with autism is that they go beyond the first few years of life. So our approach is to try to manage them, trying to minimize them as much as possible by using reinforcement of other behaviors. And we are not usually aggressive in treating them, except if they interfere significantly with daily life, such in the classroom where the kid is not paying attention to the teacher and is making a lot of noise because they are engaged in a very complex behavior that includes screaming and jumping in the classroom. But most of the time, we try to manage them and not being aggressive in treating them, except if they're affecting the functioning the functioning of the child or significantly impacting the environment. Okay, thank you for these interesting questions. I'm trying to see other questions. Yes.
Dr. Hardan, Zoya Tchaikovskaya. Please tell me if a child in Ukraine and because of war does not have access to a psychiatrist and the level of anxiety gets out of control, where there are any drugs that can be given without prescription.
Okay.
I know, tricky question.
Yeah, very tricky question. I saw it. I was trying to skip it, but no. It's a so there are some over-the-counter medications. Dr. Hassasari mentioned melatonin for sleep, and as there is another question of sleep, hopefully we'll get the chance to answer it. So one of the main symptoms of anxiety is sleep disturbances, difficulty falling asleep, and sleep continuation difficulty, which is waking up during the night. And as you all know, individuals with autism, they have that before as part of the disorder itself. Up to 90% of individual autism at one point, they have sleep disturbances. So targeting sleep with melatonin, I think, is a very good place to start. Now, treating anxiety with over-the-counter medications when access to a psychiatrist is a little bit challenging. You can check with a pediatrician. Sometimes pediatricians are comfortable recommending over-the-counter medications. Some of the medication that we suggest that are over-the-counter is diphenhydramine, Benadryl. So that's a medication that's used for allergy, but can have an anti-anxiety medication, anti-anxiety effect. Any other thoughts, Dr. Hassasari?
Yeah, this is also something that we have to be careful about recommending too. You can try some of these over-counter options, but have they been studied robustly, and is there scientific evidence that they can help with anxiety in youth with autism, right? We even the use of medications for anxiety in children without autism, the research literature is very small for supplement or over-the-counter medications. I like the idea of diphenhydramine or other antihistamines such as doxylamine. I've seen some people use that. I've seen some people use supplements like Kava or L-threonine, or one of the most effective anti-anxiety medications for adults is a medication called Selexan or lavender oil. So that's been shown to be pretty effective. But these are medications, and you know, over-the-counter means different things in different areas. So some places have benzodiazepines over-the-counter, right? And that's that's an anti-anxiety medication. And you know, I was in you know, I was in another country this year, and they had some of this selective serotonin reuptake inhibitors. Escitalopram was over-the-counter. Yeah. So I was so it just depends on where you are.
Yeah. So diphenhydramine, hydroxyzine, there are sometimes over-the-counter that you can use. Supplements can be used. Valerian is a medication.
Valerian root, yeah.
Valerian root. Yeah. So, but we have to warn you about the use over-the-counter compounds, or not only the over-the-counter, but the supplements. We don't know what's the composition, and they are not hugely regulated. But parents have used these over the years, and there is some evidence, I wouldn't say like it's very strong evidence to support their effectiveness. So these are options that could be considered.
Dr. Hadan, another question. Child immigrant, so the child who was moved from Ukraine to another country, he's now start climbing and playing with the garbage cans. I cannot figure out behavior. Could it be the reaction of the stress? Could be a neurosis, or what is going on? No information about the age or anything else.
So the question is, somebody climbs on the trash can, a kid climbs on a trash can, right? And they're trying to determine the function of the behavior.
Yeah, and this child who was moved from the war and situation, because when we was like translating some part, just like it's child refugee.
So you know, it's going to be very speculative. It's important to try to get the whole picture of that child and try to get a little bit more history. But in situations like war, or when kids are under stress, or when we are all under stress, what we observe is a regression and the development of behaviors that are a little bit unusual and not optimal. A more clearer or cleaner example is kids moving from one place to another under stress during war, and they start having bowel movement accident like enuresis and encopresis, even though that they have been totally trained for several years. So the way how they express the stress and the way how they deal with a significant change in the environment is by regressing a little bit and exhibiting behavior that they should not be doing. So that work, that interest in playing with the garbage or exploring the garbage could be classified as part of this regressive behaviors that we see when there is a significant environmental changes or environmental stressors on children in general, and won't be surprised if we see that in children with autism. Dr. Hassasari, do you have any thoughts?
Those are great things. And I think that the only thing I would add is when a child moves from somewhere familiar to unfamiliar, they often look back towards things that are familiar and try to regain that, right? So there's this, in trauma in general, there's almost like a repetition of the trauma to try to master it, right? To try to figure out something else, but they end up getting stuck in loops. And so behaviors where they're looking for that familiar could be like they're physically, like if they're not verbal, they're physically looking at, okay, where's my home, right? Like where am I, right? And so they might be standing on the trash can or in a high place to look at where they're at or try to figure out like where's home, where was home, right?
Yeah, this is so along these lines in terms of
speculative.
It is speculative and trying to look to what is familiar to the individual, and it's very speculative. We can try to see what is constant in people's life, and unfortunately maybe trash is one of the things that you see everywhere and can be linked to their previous environment. But the most important thing in this situation, it's an indicator of stress that the child is experiencing, and trying to provide assurance, trying to provide support, trying to develop a regular structure for that individual as much as possible to help them have some safety or some sense of safety in their new environment. It's not easy. It's very challenging when you're uprooted in a short period of time and you have to move to a different environment, and you lose all the constant things that you have in your life, from your bed to your toys, to your school, to your teacher, to your apartment, to your house, to your neighbors. To go to a new place, that's a very major stress. And here in the Western world, when we discuss about or in level of stress, there are the two major stressors in life is divorce, separation, and the second one is a move. And the move becomes much more stressful for a child than compared to an adult. Very good. I'm aware that we have many more questions. Sorry, we won't be able to get to all of them. We're running out of time. I just want to first thank Dr. Hassasari for this great presentation that elicited a lot of great questions. And I want to thank everyone for participating in this webinar. And next week, we will be talking about pivotal response treatment. It's the same time, Pacific time. It's from 8:30 to 10. Pivotal responding is an ABA-based intervention that helps with the core features of autism. Thank you again, Dr. Hassasari, and thank you everyone for your participation. Have a good rest of the day. And for some people, it's evening time. Have a good evening and good night. Thank you. Okay. Thank you, Dr. Hassasari. We'll see you tomorrow on video. Very good.
Yep. All right.
Okay.
Bye now.
Very good.